he's from Milan, Italy. He's the chief of endoscopy unit at the San Rafael Scientific Institute. He's going to be speaking on the topic of will EUS-BD replace ERCP? Very controversial subject, and I'm happy to have Paulo to speak about this topic with us. Thank you. Please.
Hello, everybody. Can you hear me?
Yes.
Okay, great. Thank you very much for the kind introduction. First of all, I'd like to thank Professor Tio for his kind invitation to take part to this outstanding webinar, collecting the experiences of fantastic panel of experts and giving me the opportunity to talk about EUS-guided biliary drainage. And let's check. Okay, EUS has greatly changed along years, starting from the introduction of the linear scope in 1992 and passing from the first EUS FNA procedure and the first cholangiography performed in 1996. The very first biliary therapeutic procedure was the choledochoduodenal stenting performed by Mark Giovannini in 2001, and from that point on, EUS-guided procedures have exploded in numbers of studies and trials. If we look to the papers published during the last 2 years on EUS-guided published in PubMed, there are at least more than 500 publications in 2019. And if we look particularly to EUS biliary drainage, there are 81 papers published in 2019. But besides this great enthusiasm and interest shown by the publication of these procedures, these haven't become a standard of care yet. In fact, if we look to the activity of an ERCP referral center like our in Milan, this treatment accounts less than 5% on the total activity. So why is it so? First of all, until today, these procedures haven't been shown to be first choice treatment for different indications. But second, and very important, is that as underlined by these guidelines published very recently on GATT, on interventional EUS, because these are very difficult and challenging procedures that need not only a top quality level on EUS expertise, but also a high proficiency in therapeutic ERCP. And unfortunately, there aren't training programs available at the moment to teach this kind of procedures. So what about biliary drainage? We know that ERCP is the gold standard for biliary decompression in patients with malignant biliary obstruction. In expert hands, this technique has a failure rate of near 10% due to surgically altered anatomy, duodenal structure, or tight biliary stricture. Percutaneous drainage is considered the conventional alternative procedure, but is hampered by a quite high rate of complication and a significant decrease of patients' quality of life. So different therapeutic solutions can be considered in case of failed conventional ERCP performed in experienced centers, altered anatomy, failure to access the papilla caused by malignant involvement of GI tract, occluding tumor preventing the access into the biliary tree, and the presence of a large ascites as a contraindication of PTBBD. You have already seen this picture because showing the different EUS-guided biliary drainage techniques that have been described so far. But the two more investigated and proposed in clinical settings are EUS-guided hepatogastroscopy, and Mark Giovannini has already talked about that, and EUS-guided choledochoduodenoscopy. If we think about EUS-guided biliary drainage and choledochoduodenoscopy, this can be performed using several different devices, but roughly there are two main techniques that can be considered. The first one is the standard, using EUS to gain the access to the biliary tree and then completing the procedure using fluoroscopy like a standard ERCP. And this can be called the needle wire technique. And as is shown in this video by byPaolo in his paper on gastrointestinal endoscopy in 2008, you see here that the needle is puncturing the biliary tree, and then the guide wire is passed after the contrast injection, and then there is a dilation procedure, and on the dilated tract, the stent is usually normally deployed. The EUS-guided CBD second technique has been introduced with the development of the electrified cautery fully covered lumen opposing stent, which can be used completely under EUS guidance without fluoroscopy and need of needle and guide wire. This could be called the wireless technique. These are a series of lamps that are on the market, actually, and the use of this device could greatly speed up the procedure, but these have some limitation due by the design of the devices. In fact, if you can see here, the release of the distal flange that is performed retracting the outer sheath needs at least a 2.2 centimeters of space for a safe deployment. This obviously reduces the number of patients in whom to apply this technique and increases in some cases the difficulty and the underlying risk on this technique. The first step of the procedures, as always, consists in the evaluation of the optimal site of the puncture, avoiding the hilum here, and also the distal and also the cystic duct conjunction with the bile, with the common bile duct, and also avoiding to be too close to the in too close proximity to the tumor. The second step is to take care about the vessels and to see that if there is no intervening vessel on the tract. This is the ferra vena cava, this is a portal vein. Then the procedure can start, and the procedure can start and can be done completely under EUS guidance. The pure cut current is used to create the tract, and the distal part of the device is pushed to the distal wall of the CBD in order to gain enough space to deploy the distal part, the distal flange of the stent. And the deployment of the stent is completely controlled by EUS using a freehand technique. This means that the outer sheath is left unlocked and is continuously adjusted in order to be able to deploy the distal flange inside the CBD, like in this case, as you can see here. Very, very gently, we release the distal flange, moving the outer sheath until the distal flange is released. And then, after the release of the distal flange, the procedure is complete with an intra-channel release of the proximal flange that is pushed outside the scope, opening gently into the duodenum, like in this case. So, as always, these procedures can be very easy to perform. It seems to be sometimes very easy to perform, but it should be important to be aware of the fact that sometimes this procedure can fail, and the failure of this procedure is usually depending on the diameter of the CBD, like in this case, because the distal part of the device is pushed too much away from the proximal part of the CBD, and then when the stent is open, you see here that the stent has passed throughout this CBD and this pinching the CBD here. So this is very important to be aware of this possibility and to be ready also to see whether this possibility, this complication has come, like in this case. And in this case, the endosonographer was able to clearly visualize the fact that the stent was outside the CBD, and so the PTBD was possible to as a salvage therapy of this procedure. So many papers have been published on the use of EUS-CBD drainage after failed ERCP, and most of them are collected in this systematic review and meta-analysis, showing that the technical success rate and the clinical success rate and also the early adverse events are very, very effective for this kind of procedure. But these are all papers published as a salvage therapy in cases of failed ERCP. But if we look to the activity of a high quality ERCP center, like in this case, in the Varada-Ayulu paper, you can see here that the EUS-guided drainage was considered to be necessary only in no more than 2% of the cases. So how we can manage, how we can change this evidence? So we need to perform trials comparing EUS biliary drainage versus ERCP in an upfront procedures. So as a primary treatment of biliary malignant involvement. Obviously, on the altered anatomy and duodenal involvement and papillary involvement, EUS could be considered as a safe procedure to substitute ERCP, but in all the other indication, we have to compare EUS-BD versus ERCP on all these variables: technical success, clinical success, procedural time, complication, quality of life, and survival of the patients. As I told you, in the cases of an accessible papilla or in cases of inaccessible duodenum, EUS-guided biliary drainage has been shown to be really effective and better as compared to endoscopy and to ERCP in the drainage of the biliary tree, both for technical success and clinical success. But what's happening if we consider as a primary non-native papilla? This is the very first multi-center randomized control trial published in the American Journal of Gastroenterology 2 years ago, comparing ERCP and EUS-BD. And as you can see here, EUS-BD was shown to be significantly better as compared to ERCP in the procedure time, in the reduction of adverse event, and also on the reintervention rate. It should be shown that particularly on acute pancreatitis, probably the complication of acute pancreatitis in this ERCP group has been shown to be very high, and this probably was related by the fact that there was no prophylaxis of pancreatitis in this ERCP group. But the data are quite impressive on this side. This is the second randomized control trial published comparing EUS-BD and ERCP as a primer. And as you can see here, there was no difference in technical success, clinical success, and also in adverse event. The only significant difference was on tumor ingrowth, because there was a significant ingrowth in the ERCP group as compared to the US group. And finally, this was the third year's randomized control trial comparing the two methods performed in Florida. And as you can see, there was absolutely no difference in any kind of the variables studied among the two techniques. And this was the very last prospective multicenter trial comparing US and and ERCP, showing also in this regard that there was no difference. Many meta-analysis has been published so far, and the last one just recently published on the literature this year in digestive endoscopy suggests that there is absolutely no difference in technical and clinical success rate between EUS-BD and ERCP, but there is a significant difference in terms of pancreatitis rate, and this is quite understandable because EUS-guided procedure do not impact on pancreatic duct during the attempt of cannulation of the papilla, and there are absolutely no other differences, significant difference in terms of other adverse events. But if we look to the stent dysfunction and stent occlusion, there is a slight benefit in favor of EUS-BD on the long run. And more important, there is a significant benefit of EUS-BD in terms of tumor ingrowth, because obviously the stent in the EUS-BD is deployed far away from the tumor, so the tumor ingrowth is quite less than in ERCP, but this is not impacted on reintervention at the end, on reintervention rates significantly. These are two papers that I'm going to present you, considering the role of these new fully covered lumen opposing stents. This is very interesting, from a multicenter French group, showing that at the univariate analysis, risk factors of technical success in the use of these lumen opposing stents are the bile duct diameter more than 15 millimeters and the use of an axial stent of 6 millimeters, and the use of the recommended wireless technique. And this is the very first multicenter experience from the United States that shows that, particularly to reduce the risk of stent occlusion by food infection, could be useful to put a double pigtail stent inside the lamps in order to avoid food infection. So, in conclusion, we can say that the EUS biliary drainage has shown to be considered the first choice in case of ERCP impossibility of ERCP failure, and as an upfront technique instead of ERCP in distal CBD malignant stricture, EUS-BD has shown to be as effective and safe as ERCP, and so to be that can be considered in expert hands to be a first choice treatment. There are no randomized controlled trials comparing ERCP with the EUS biliary drainage using the hot lumen opposing stents, freehand technique. And furthermore, we need, as always, for EUS technical improvement of the actual devices in order to obtain an easier and safer deployment also in a small size CBD. So coming to the question of my talk, if EUS-BD could replace ERCP, I think that until nowadays we cannot say that, but what we can say is that probably actually there is more than one way to skin a cat. So EUS-BD drainage could be used in these cases. Thank you very much for your kind attention.
Thank you very much, Paolo. Very nice talk. I think we have time for about a couple of questions, and I will start first with a question. In your practice, do you have any specific algorithm or strategy as far as when you would choose ERCP upfront, or when you would choose EUS upfront, or would you try everyone on ERCP, and if you fail, then you do EUS?
That's a nice question. Unfortunately, during these days, we are participating to a multi-center trial. The principal investigation is Anthony Tio, comparing ERCP versus BD as a first step. So actually, we are randomizing our patients with a locally advanced pancreatic cancer in order to perform EUS-BD or ERCP. In other cases, before this randomizing trial, we always perform CBD drainage, EUS-guided CBD drainage in terms of in patients with duodenal stenosis, duodenal strictures, or impossibility to assess the papilla due to tumor involvement of the papilla, and on the failure of ERCP. So in all the patients with the native papilla accessible, we start with ERCP, and then if we fail, we go to EUS-BD.
Okay. So then do you normally consent your patients for both procedures?
Yeah.
Okay.
Absolutely.
Okay.
Yeah, because actually we do, our schedule is to perform in one session EUS plus FNA for the diagnosis and staging of the malignancy, and on the same session ERCP. So during the same session with EUS, we also look previously if we could perform EUS-BD drainage in case of failure. So we are aware of our possibility from the beginning of the procedure. So the patient has to consent signed.
Okay, very good. Okay, very good. Suppose do you want to ask a question? Did you raise your hands earlier?
Maybe you can answer some of the questions in the.
Yeah, we have a lot of unanswered questions, so maybe I'll just go through all those, and you guys feel free to answer the questions. So let me go with this. In surgically altered anatomy, like post-Whipple, do you prefer antegrade stenting or HGS, or no difference? Maybe Paolo, you can answer that.
Oh, I try to perform hepaticogasto in these cases.
Okay, okay. I think Vinay had mentioned earlier that he liked antegrade stenting if possible. I don't know if Vinay is still around, if you want to comment on that.
Hi, Natali.
Hi.
Yeah, I was listening to Paulo's lecture and the lecture before that. Fantastic session, very, very nice lectures. Paulo, great lecture. My choice is always antegrade first, always. HGS is only for failures of antegrade. Only patients who have tumors at the papilla, at or around the papilla, I will go for HGS first. Like Anthony's case, in which he did the HGS, or had a narrowing at the duodenum because of tumor. In such cases, I would say HGS, but if papilla is open, I would go for, or it's a post-surgical anatomy, I would go for antegrade.
Okay, all right. And the next question is, which wire you use for EUS-BD? Maybe we can ask each one of you, Paolo, Professor Kita, and Mark. your wire preference?
I usually don't use the wire because we use the wireless technique. So I directly puncture the CBD with the electrocautery device and perform one-step release. So we don't use the guide wire usually.
Oh, okay. Professor Kira? Oh, he might be gone. Maybe Mark, which is your preference on the wire? Mark is not here either.
He's gone.
Yeah.
Right. Anthony,
I'm here.
any comments on the wire? Any preference?
Just now during the live, yeah, we were mostly using the 025 basic light. Sometimes with difficulty, we can use the Chirima.
Okay.
Prefer the angle tip wire.
I see. Is there a risk of delay bleeding with the use of hot axios, especially with the presence of many collaterals? Maybe Paulo, do you have any experience on delay bleeding from?
We are lucky we didn't experience any delayed bleeding. The problem is that the two important things that you need to perform this procedure with the hot axios is to clearly look for the vessels intervening in the tract, the first thing, and the second one is to use pure cut. If you use pure cut and so you avoid coagulation current, then you don't have any risk of delayed increase of the necrosis around your tract that usually can cause delayed bleeding. So the two things are those.
Okay, I see. I think we have time for just one more question, and I'm going to choose this question from the audience. Bleeding seems to be more than expected. What are the steps of it? What are the steps if the bleeding doesn't stop or if the patient develops melena? For example, in Shannon's case this morning, there was a little bit of oozing there. So the question is, what should we do? And if the patient developed melena, what would be the next step?
I think for that case, the patient also have portal vein thrombosis, so it's very common to have a lot of collaterals. For LAMS, I think it tends to with the expansion of the metal stand, it tends to be able to cause compression of these veins. I think if there's a lot of bleeding, we can certainly dilate the LAMS so that it becomes the planned size sooner, so to provide better compression onto the duodenal wall. And then we can keep that balloon inflated for a couple of minutes and then observe. I think generally with venous bleeding, it will tend to stop. Sometimes if we use a hot axios, the cautery tip can injure the bile duct inside as well. For those patients, the bleeding tends to stop by itself. We will insert a double pigtail stent through the hot axios. Observe for a while. Usually it would stop by itself. If you're worried about a blood clot clogging the stent, maybe you will need to do a follow-up scope the next day. Make sure the clots are passed out, and if not, you might need to clean the bile duct through the axial.
Okay. All right. Thank you so much, Anthony. With that, I'd like to conclude the session, and I'd like to thank all the speakers, Professor Mark, Giovanni, Professor Kita, and Professor Paulo. I hope you had a great time with the session. And I think we have a 15-minute break. Is that right, Anthony?
Yes, before the break, can we try to turn on all the cameras so that we can have a nice Zoom photo by Flora? if by all the ones who are still here.
I'm taking a photo.
Zoom photo. Yeah, this is now the chair.
How do you bring everyone on the screen?
Remove your finger, Nantali.
Oh, okay.
Okay. Okay. Oh, okay. Come on. Okay. Oh, good.
Wait a minute more. I'm taking a picture actually.
3, 2, 1. Okay, picture. Okay. Oh, come on, you see? One more.
What are you doing
Picture.
now?
Picture.
Picture, photo time?
Yes, done already.
Ah, Shannon is here. Wow.
Hey, Shannon, nice job.
All right, so we need to move on to break. So I'll hand the screen over to Flora. Okay, so we're now back to the last session of mute sessions computer. So for this session, will be me and also Yasuda Sensei doing the moderating. And next up, we will have one of the giants in EUS-BD drainage, Itoi Sensei. So he will be talking to us on EUS-guided anti-grade stone extraction techniques and outcomes. So Itoi Sensei, please unmute.
Can you hear me?
Yes.
Thank you so much, Anthony, for kind introduction. Hello, everyone. I'm Takao Ito in Tokyo. First of all, I'd like to say thank you so much, Anthony and Lawrence, for having me in this wonderful international webinar. Okay, so time is limited, so let's get started. My slide. Can you see my slide?
Yes.
Okay.
Yes, we can.
Yeah, yes, thank you so much. Okay, let's get started. My topic on the EUS-guided and grade stone extraction or stone removal. You know, nowadays almost all stones were able to be extracted by standard ERCP, right? However, in some cases in normal anatomy or in patient with the surgical altered anatomy, ERCP is not always successful due to the long afferent loop or upside down papilla, severe stricture of the anastomosis, etc. So, you know, recently the single or double balloon enteroscopy assisted ERCP are available in such patients. Basically, I love this procedure. However, you know, the technical success rate is not so high. Even in a unit, we have full expertise of this procedure now, but the success rate is not 100%. As you can see, the final, the success rate is 88%. In other words, even in our unit, expertise endoscopist unit, the ERCP is failed in 12% of GI altered anatomy cases. In order to overcome this issue, interventional EUS for stone extraction is emerging now. I believe that it is good not only for the patient but also the endoscopist. So as you can see, EUS-guided antegrade stone removal. Antegrade stone removal by a biliary drainage route, mainly hepatico-gastrostomy route, like a PDBD, may be promising technique for salvage treatment in failed ERCP cases. By the way, you know, as you can see this slide, there are mainly two techniques of this procedure. One is a real one-step stone extraction without any stenting of the procedure, just finish. And the other is a two-step, so-called a two-step stone extraction technique. In the real two-step, I mean the real two-step, the stent is placed in the first session, and then stone extraction in another session. It is a real two-step, but in some cases modified. First right, one step, but interruption of the procedure due to the long procedure time or patient adverse event or something, and then once the stent placement, and then later in another session again replace. This is a modify the two-step technique. So what is the indication, or who is a good the operator in this procedure? I think I think indication is all difficult bile duct stone, almost all. However, in terms of operator, I believe I need expertise for both ERCP and EUS because we need a lot of devices, new devices, or new knowledge of the devices or scope or something. That's why, if possible, the expertise for both technique is mandatory. So you can see this procedure, one by one I explained. The puncture is 19 gauge is much better, but in case of stone cases, usually no dilation of the intrahepatic bile ducts. That's why. So sometimes we have no choice to use a 22 gauge needle. And which branch is much better? I think B2 is much better because trackability of the devices are much better comparing to the B3. But in some cases, no choice. B2 means up to above the EG junction or something. It's very dangerous. So benign, Professor benign, so no problem. But I think a big problem sometimes. And the B3 is sometimes easier than B2, but once we create a fistula, the maneuverability of the device is not so good comparing to the B2. And the guide wire is 0.25-inch hard type guide wire. Basic wire 2 is much better. But in case of a 22 gauge needle puncture or 1/8, usually now the no good 1/8-inch guide wire, no choice, but we use sometimes. And in terms of thrust duration, the mechanical thrust duration is much better. So in Japan, we fortunately have ES dilator, or dedicated dilator of the EUS dilation. And otherwise, small balloon, hurricane balloon or Japanese balloon is much 3 millimeter, very nice balloon we use. And lastly, no choice, cautery needle, cautery dilator. Sometimes we have to use, but very rare now because of a benign biliary disease. And the stenting, in terms of stenting, now we can use a dedicated plastic stent. So due to the, because of a benign diseases, so we frequently use a plastic stent first. And in some cases, we use a metal stent. What case? For example, the very large dilated, very dilated bile duct, and maybe when we use SPIDS or something cholangioscope, at that time we firstly use metal stent, and then in terms of extraction. Of course, we need to use guide wire type balloon or basket, and the lithotripsy. In some cases, we need the lithotripsy. At that time, also we have to use a guide wire type, mechanical lithotripsy, monorail type provided by Olympus company, or cholangioscopy assisted EHL. So here you can see our first, this is the first outcome. At this moment, we used to use a one-step technique. So since it was difficult to extract the stone completely at this moment, that's why finally we use balloon enteroscopy assisted ERCP combination technique using a rendezvous technique. And so the success rate is over one-step technique is only 60%, 5, and totally 100%. It is their outcome. So at this moment already, so we are already wondering if the long-term procedure causes adverse event like bile leak or something. That's why. So after this experience, we change our mind, manually shift to the two-step simple and the real two-step procedure, except the simple small stone. And you can see the multi-center study outcome described by Dr. Iwashita. It shows the success rate is 72% and without serious complication. And the procedure time, it was 45.5 minutes. So I think at this moment, this data is can't complain. So this is our latest data, including not only stone cases, but also the stricture cases. And the success rate is already 92% with a serious adverse event. As long as stone cases, it was nearly 100% in this article. And we are very comfortable for this outcome. Okay, so next I'd like to show the movie. This is a total gastrectomy with Roux-en-Y case, CBD stone, small stone, very small stone, a lot of very small stone. And firstly, the puncture using a 19 gauge needle, and you can see a CBD stone, a lot of small CBD stone. And guide wire insertion and the looping in the bile duct because of large dilated bile duct, and then using a catheter. Sometimes it needs a catheter to penetrate to pass across the papilla. And firstly, small balloon dilation up to 10 millimeter, so-called the EPBD, and then immediately after deflation, the small stones, naturally, spontaneously came out of the bile duct to the duodenum, and finally the small stone was there. Then again and again, but small stone was there, and a little bit larger balloon inflated. So gradual inflation is necessary to avoid unnecessary unexpected bleeding or something. And the balloon, usually so we use the balloon first and push. Gradually deflation in combination with assistant and push the whole stone. And finally, to keep the stone fistula trunk, we place a plastic stent. Actually, in this case, 1 month later, we check the residual stone, and surprisingly, one residual stone was there, and finally, the whole stone push out, and this removal of the plastic stent. In the another case, this is a one step. So not so dilated bile duct into hepatic bile duct, but fortunately the nicely cholangiogram was obtained. And again, using a catheter to confirm the stone was impacted. Stone was impacted above the papilla. And the guide wire passed through the papilla. And as I mentioned, firstly, small stone to avoid the compressor stone to the bile duct, and they going up to the hilar portion. And then appropriate size of balloon matched to the stone size. And finally, the egg-like, not so square type shape, egg-shaped type stone is very easy to push out from the bile duct. And this is a hepatico-jejunostomy cases. A lot of stone was here. And again, So very nicely, the cholangiography. Oh my goodness, a lot of stone. Firstly is a anastomotic structure dilation, gradual dilation, and then little by little, one by one, not one by one, 2 by 2 or 3 by 2, 3 by 3, push. Gradually depression, combination with assistant technique. Almost all stone was extracted from the bile duct. And finally, no stone was there. And this is a simple and a very nice technique. And this is a case of usage of mechanical resotorptor. So Olympus wire-guided mechanical resotorptor is available during this procedure, one-step procedure. This is a mechanical resotorptor provided by Olympus. Square type stone. Firstly, we tried the standard technique, balloon dilation up to the same size of the stone, but due to the square shape, couldn't push out. And no choice using guide wire type resotorptor, mechanical resotorptor, and the crash, small fragment, so one by one push out. And this is another option of the resotorpsy during this procedure. Anyways, recently this is a standard technique using cholangioscopy assisted EHL using by two-step technique. You can see a lot of stone. They are maybe impacted stone. That's why. So standard the push-out technique will be not available. That's why. So after removal of the stent, we insert cholangiography. The scope is a TGF. You can see. This is the second two-step technique, and so this is impacted stone. And you can see very nicely the straight position in front of the stone, very nicely. And the retrovator using AHL. And the combination with balloon dilation of the anastomotic side and push the stone. Or sometimes retraction, like this from the intrahepatic bile duct to the stomach. And finally, the complete extraction. This is a final case, huge stone, then the hepatic angiostomy. Maybe the patient, some doctors say that, to the patient, you should be the operation. That's so refuse and is referred to our hospital. And the schema is like this. The first is, of course, in this case, we have no choice to use cholangioscopy assisted EHL later. That's why first session the metal stent was placed. So skip very large like this. I hate this situation. So it takes, I think it takes a long time to complete extraction of the stone. Finally, the metal stent was placed after dilation. And then after this, 10 days after this procedure, 10 days, patient upset to back to his job. That's why so we need short time the therapeutic days. And then second session, I'm not sure that only 10 days to mature the fissura. That's why through the mesh technique to keep the metal stent left. And then fortunately you can see a very huge large stone there in front of the cholangioscopy. And the same way, and after fragmentation of the stone, the removal, retrieval, and the push a stone. Very tough structure, very tough stone, but finally, the cholangioscopy showed no residual stone completely. It needed 2 sessions from the first 3 sessions. Anyway, the patient was very comfortable. This is the CAT scan, the huge stone, but so finally you can take it. So, ladies and gentlemen, in my conclusion, EUS-guided antegrade stone extraction is useful for difficult bile stone, and it is but still limited in the center where the EUS and the ERCP expertise is present. And I hope new devices in near future. So finally, I'm sure now it must be still a very, very stressful time for you. Please stay safe and healthy. And I'm looking forward to actually seeing you again when the crisis is over. So let's overcome this situation together. No coronavirus. Thank you for your kind attention.
Thank you, Itoi Sensei.
Yeah, thank you, Itoi Sensei. Very beautiful presentation.
So I think we have some questions on the
from the audience.
Chat. So Itoi Sensei, what is the best wire for antegrade stone extraction in your experience?
It is a good question. I use usually the 2 types guide wire. One is standard 025 basic guide, very hard, and the another guide wire is Boston Scientific very hard 035 super hard wire. Sometimes very useful, but the standard guide wire is Olympus, so basically 90%, 90% basic guide 025.
Yeah, and from the audience, there are one question. What's the risk of bile duct peritonitis with the procedure? And is there a need to close the defect in gastric wall using OTSC after stone clearance?
Yes, of course, in case of a one-step procedure, the risk of a bile leakage, and during the procedure, risk of much bile leakage. But that's why I recommend the 2-step. Firstly is just put pressure stent placement, and then after maturing the tract anastomosis, and then we can perform easily the stone extraction later. Yeah, No, in case of one step, I think no need of base core or something, because the gastric wall is very small.
Oh yeah. So the U means one-step procedure is one day you perform the puncture and inserting the balloon catheter and the balloon and the push out the stones in the same day.
Yes. I perform some cases and they finish because of a small stone, very easy, and a small stone and usually no problem. But a big stone or huge stone or complicated stone, we recommend a two-step. But basically now we need a two-step.
And another question from the audience: how long need to wait between two sessions in two-step approach for EUS stone retrieval? That you mentioned 10 days after first sessions, you perform the cholangioscopy and EHL destruction of stones. Is that right? 10 days is enough?
I'm not sure, but at least if we can use a metal stent, 10 to 14 days enough. But in case of a plastic stent, you know, the like a PTBD, at least more than 2 weeks, 14 days, or up to in some cases 1 month is necessary. That's why. So in case of a plastic stent, we use just press a plastic stent and then discharge, and 1 month later go back. Yeah, readmission.
Okay.
Yeah.
So Anthony, do you have any comment?
There's one more question. Any experience with laser lithotripsy?
So of course we have both laser and the EHL, but the EHL, I love EHL because the crash power is much better. Laser is just you know, make a hole. Point. Yeah. That's also EHL. I love it.
I agree. I totally agree. And the price is cheaper than laser. EHL is cheaper than laser.
Yeah.
Okay, so I think we should move on. Thank you very much, Itoi Sensei, for a great lecture.
Yeah, thank you very much. Very beautiful presentations. So may I introduce the second case, second paper?
Yes, please.
So the next speaker is Professor Manuel Perez-Miranda from Spain. Professor Manuel?
Unmute yourself.
Yeah. How can I say buenos dias? What time is in Spain?
Very good. I'm okay. Let's see if I can share my screen with you.
Oh, not yet. Oh, now it's coming.
Is it okay now?
Yeah, we can see.
Okay. Can you see? Okay. Yeah. So it's an honor to be in this webinar with my Asian EUS group friends and especially Professor Tio and Professor Yasuda, my moderators. This is July the 11th in Spain. It's close to 9:30 a.m., which is about the time you started. And I'm going to let you know why July the 11th is a very important date for us, because just this day, 10 years ago, it was the first time Spain won the World Football Cup against some dirty play with the Dutch, but that's another story. So let's get focused on EUS-guided enterostomy for biliary access. I want to give you briefly some background, discuss afferent loop syndrome, which is not exactly for access, but biliary decompression, but a related enterostomy, EUS-guided enterostomy approach. Then what we call, or is coming to be known as EDGE, for Roux-en-Y gastric bypass. What the Americans, which are very fancy with these catchy acronyms, call ED for non-Roux-en-Y gastric bypass. The differences between one and other approach, and then summary and conclusions. So if you look at these exstellar consensus guidelines by your group, a lot of very thoughtful people, a lot of very knowledgeable people here, all of them friends. They classify EUS-guided biliary interventions into access techniques such as rendezvous, and EUS-guided biliary drainage such as antegrade stenting or transmural drainage. So I would be daring enough to say that this classification is currently a little bit incomplete. It's becoming a little bit dated because we see no indirect non-ductal targets for drainage. For instance, this is an example by the Kitano group from Osaka, when sometimes we have to use the gallbladder instead of the duct as a target to achieve not gallbladder drainage, but ductal drainage. This is 135 patients where ERCP failed. Most of them were salvaged by EUS-guided biliary drainage or PTBD. However, in 12 patients where EUS-BD failed, the gallbladder could be used as a target to decompress the bile duct. This is an example of indirect biliary drainage. The other important background concept comes from our colleagues in interventional radiology, which is transjejunal access for bile duct decompression. This is patients with insufficient intrahepatic dilation, often with benign multiple strictures after following surgical hepaticojejunostomy. And you see, for the radiologist, it's much better to access the bile duct retrogradely through a fixed loop of jejunum than antegradely via PTBD or PTC. Interestingly, this is a study from South Africa, some 59 patients. They underwent close to 500 procedures over 2 decades. That is giving us another important clue about these patients. These patients often have relapsing stricturing, recurrent hepatolithiasis, and need iterative access. That means the patients are okay for 2-3 years, then they need revision. And for the radiologist, this is much better accessing the loop through the jejunum than having the patient wear a permanent internal-external drain. So I wanted to briefly mention one EUS-guided enterostomy technique before discussing access proper. This is afferent loop syndrome because there is increasing use by HPV surgeons of Whipple and other indications. This is becoming more common. And as you all remember, this afferent loop syndrome is due to an increased pressure because of obstruction downstream in the loop, most commonly because of tumor recurrence, sometimes may be caused by benign stricturing, and most often this increased pressure here manifests as cholangitis, abdominal pain, vomiting, sometimes pancreatitis. And this nice scheme by Tokyo Medical University, Dr. Itoi's group, shows how with EUS we can access directly the loop. In the past, these patients were often managed percutaneously, which is suboptimal. It impairs patients' quality of life because they have to wear permanently an external drain. And CT imaging shows us how close the afferent loop is to the stomach. And from the stomach, we can decompress using a lumen-opposing metal stent or even a plastic stent or a conventional tubular metal stent, the afferent loop into the stomach retrogradely. The hot axios, this has become much more simpler. This is the original report, the first freehand technique, the first report of the freehand technique in the world, and it was precisely used in one afferent loop case. This is Dr. Itoi. I'm going to mute him, and you see how he burns into a very distended segment of jejunum, giving rise to afferent loop syndrome, deploy the distal flange, retract, and then deploy the proximal flange under combined fluoroscopy and endoscopic view. And this has become very, very popular. This is rapidly replacing other approaches to afferent loop syndrome. So the same freehand technique, when used for the gallbladder, shows a different, even with hot axios, the stent deployment time drops from 7.7 minutes to 3.1 minutes. So for a small bowel anastomosis, this is very important. So freehand into technique into a sufficiently dilated segment of small bowel or stomach is, I would say, much efficient and much safer than even if you have hot axios, putting a needle, then a guide wire, then the hot axios. This is becoming more and more used everywhere. So before I finish afferent loop syndrome, this is a nice retrospective multi-center USA study led by Mowinke, in which he compared the results for afferent loop syndrome for the EUS-guided enterostomy in 18 patients versus antegrade luminal stenting in 17 patients. And look at this, even if the technical success was high in both arms of the retrospective study, 100% for EUS enterostomy and 90% for antegrade luminal stenting, complete resolution of symptoms was seen almost 90% in the EUS group versus only 6% in the antegrade luminal stenting. This is a very important point in difference. So in other words, even if we can do this by endoscopy without external drainage, by stenting the stricture in the afferent loop, the clinical efficacy is much higher by retrograde stenting. So the need for intervention is another important difference. It was only 16% in EUS-guided enterostomy, whereas it was 76% in luminal stenting. Again, this favors the EUS-guided approach. So in other words, we endoscopists are no longer doing in afferent loop syndrome luminal stenting because we can create enterostomy by EUS, which is technically easier, clinically more effective, and in the long term, less incidence of dysfunction and less need for reintervention. So now coming into enterostomy for biliary access, the so-called EDGE technique, the rationale for this is that in very long limbs, such as in Roux-en-Y gastric bypass, which afferent limbs often in excess of 150 centimeters, the success rate of enteroscopy-based ERCP, whatever the technique, is much lower than the already low 70% for all other indications. So, and again, we have excluded antrum, excluded the gastric remnant, which is very easy to image and which we can very consistently puncture with EUS and create an anastomosis. Then there are other cases, such as in Roux-en-Y biliary reconstruction, Roux-en-Y hepaticojejunostomy, which is very similar to the situation that I showed you in the beginning for the interventional radiologists. These patients have often recurrent stricturing. They need a complex intervention, iterative access for hepatolithiasis. And even if enteroscopy-assisted ERCP might not be so difficult because this limb is shorter than in Roux-en-Y gastric bypass, sometimes there are many, many surgeries in these patients. They have cholecystectomy, then they have reconstruction for a severe bile duct injury, then maybe they eventually needed a liver transplant because of secondary liver cirrhosis. So these patients are what are in the past were called biliary crippled. So now these days we'll say biliary disabled, which sounds more politically correct, but it means the same thing. These patients are having chronic need for intervention, and creating a bridge for from the stomach or the duodenal bulb into the afferent limb greatly facilitates reintervention. Even if enteroscopy assisted is very, very easy. So that is the rationale behind creating a bypass for Roux-en-Y gastric bypass, which is becoming increasingly common both in America, in the United States, and in Latin America. So you see here from the pouch, we can image the antrum. Sometimes we have to drive the endoscope into the efferent limb to image the gastric antrum. And the process is just like any other EUS-guided LAMS insertion. In the past, we needed a guide wire, serial dilation, stent placement, balloon dilation, and then through these 15 millimeter axios, you cannot see, can you see my I guess you can see my arrow, my pointer. We can go through. This is one of our cases, and it shows just how easy it is. In this case, by inadvertently, we access the duodenum, we put a lot of contrast, then we rotate and we see the excluded antrum. And this is a case in which the advantage of the EUS-guided approach over the laparoscopy-assisted transgastric ERCP is shown. This is a patient who already had cholecystectomy. Therefore, surgery is not very desirable in a patient after cholecystectomy. The patient had a leakage, so we created this conduit by, and you see initially we were imaging the bulb. We put some contrast through the needle, and then immediately under fluoroscopy, we rotate and we realize we have a much better access into the antrum. And here we can do freehand insertion because it is nicely distending. These days we use the 20 millimeter, which allows a single section ERCP. We balloon dilate up to 18, and then it's easy to pass a duodenoscope into the antrum through the pylorus, and then we can just do normal ERCP cannulation, sphincterotomy. We are through the axios here. We do stone removal, and in this case, for safety, we place a 10 French plastic stent. We know that even if sphincterotomy and stone removal is enough, it is more efficient to place a plastic stent. So, and then we pull out, leave our axios, waiting for the leak to go away, and we have a nice access. Again, in this patient, we had a persistent leakage. So we have to go back again, exchange the plastic stent for a fully covered biliary metal stent, second procedure. And eventually, we also left a double pigtail in case there was some intrahepatic leakage that we were not able to see. Eventually, the leak resolved, and we did a third procedure. We pull out the pigtail, we pull out the metal stent. I remind you, this is a patient after cholecystectomy. And then in the same session, we can remove the 20 millimeter lens. You see the access was created from the efferent jejunal limb. And this fistula, we can let to heal. It will heal spontaneously, nearly virtually always. Sometimes we leave a double pigtail. Occasionally, the Americans are they like a lot to suture and do more things. but in our experience, this is not necessary if the stent has been in place less than 4 weeks. So this again shows the advantage of the EUS-guided approach versus the lap-assisted. This is a recent meta-analysis published this year in EIO. There are a lot of balloon enteroscopy ERCP and a lot of these EDGE procedures, not all of them. And you see the number of patients currently reported is slightly over 100, 150, I would say, because there are some studies missing here. It's close to 200 for EDGE, and the number of patients in balloon enteroscopy ERCP is becoming less and less. There was, in this meta-analysis, which is done by surgeons, there are a lot of lap-assisted ERCP, and you see the 3 arms: EDGE, lap-assisted ERCP, and balloon enteroscopy ERCP. The technical success is equally high for EDGE and lap-assisted ERCP, much lower for balloon enteroscopy ERCP. The clinical success is even less so for balloon enteroscopy ERCP. There is some post-procedure pancreatitis, which is higher for balloon enteroscopy than for EDGE, even for intraoperative ERCP. Maybe this is because some of the endoscopies doing lap-assisted ERCP are surgeons, and maybe they have a lower volume ERCP. And then, of course, some bleeding. Interestingly, if you have bleeding from the papilla with EDGE, you can go back very easily and do sclerotherapy on the papilla. There was some perforation and some stem migration. Again, the adverse events is slightly higher for EDGE and lap-assisted compared to balloon enteroscopy, around 5%, but 5 to 20% if you count other, such as stem migration, which is sometimes may not be a complication, but is counted as a complication. And you have an increased incidence of complications coming from infection in the wound. So, my conclusion for EDGE, for Roux-en-Y gastric bypass, is as effective as lap-assisted ERCP, is preferable to a combined procedure from the logistics point of view, because you don't have to go to the OR, you don't need general anesthesia, you can do endoscopic sedation, you do one-step procedure with a 20 millimeter, you don't need any suturing, any anchoring of the stent with a 20 millimeter, and you don't need to close the fistula. And the small percent of patients that need something beyond stone removal, you can go back for stent removal, stent upgrade, to treat post-sphincterotomy bleeding. So to me, there is no need to do lap-assisted ERCP unless perhaps the patient already needs a cholecystectomy and it can be done in the same session. So for that case, a patient with the gallbladder in situ, maybe we can use that surgery and we have to go to the OR. Balloon enteroscopy, I don't see the benefit, honestly. And how this compares with EUS-guided direct approaches, I would say that very often these patients have stone, sludge, relapsing pancreatitis. They need a sphincterotomy, or they need, and this is not very easily done by an antegrade EUS-guided approach. Okay, how about the non-Roux-en-Y gastric bypass patients? How about what it is called ED? In this case, this is the first reported case we did. It's just a case report we did in 2013 and presented at the video forum in DDW the following year. It was a malignant indication, a patient with a Claskin, a left hepatectomy, and a trisegmental anastomosis. And basically, we had to resort to this in the days of the cold axios because the patient could not be palliated by EUS-BD, which was technically successful, but we could only get one of the 3 branches. You see, this is tumor recurrence, and you see there is 1, 2, and 3 points of stricture, and the right side was not accessible from the duodenum. We could not image. The patient also had PT-BD. It was technically successful, but again, it could not be internalized, and the patient was still jaundiced because there were 3 branches. So eventually, we tried enteroscopy, but by enteroscopy, we could not put the stent. The stricture was too tight. We didn't have a pushing force to place the stent. We took advantage of enteroscopy to leave a nasobiliary drain close to the afferent limb, and then we put fluid through the drain so that we can image afferent limb, did a puncture with a 19-gauge needle, and then over the wire, after dilation, place a 15-millimeter cold axios. And the beauty of patients with hepaticojejunostomy is that you don't need a duodenoscope with a rectangular section. So that we can use a regular or a therapeutic forward viewing upper endoscope. And in the same section, we can go through the 15-millimeter axios and do serial intervention in the bile duct, like triple stenting, such as in this case, right? So with enteroscopy, we were not skilled enough. Maybe for a skilled Japanese operator with a dedicated therapeutic enteroscopy for ERCP endoscope, this triple stenting would have been easy. You have a less length of scope. But even sometimes these patients, as I said, they had a lot of additions. And when we have tried balloon-assisted enteroscopy, we have had mesenteric hematoma, we have had complications, and especially this is a malignant patient, so we're just aiming for one intervention. But when this is benign and you need to do balloon dilation, stent placement, stent removal, stone removal, even if you are skilled with enteroscopy, this is not very convenient. There are only 2 published series. One, which I think it really shows the proper indications for these patients, coming from my friend from Italy, Massimiliano Mutignani, who was published at the end of last year, an endoscopy. And you see this is a patient with a severe benign bilateral post-hepaticojejunostomy stricture. So by using a lams from the bulb or the antrum into the afferent limb very close to the anastomosis, Mutignani is doing very aggressive dilation, placing balloon dilation and then fully covered metal stent, 4-centimeter wall flex, and then leaving the stent in place and then go back through the lams and recalibrate the stricture. So in the Mutignani series with 32 patients, they were technically successful in 31. They have 1 acute complication, which is below 5%, and then over follow-up, they have 5 complications related to stent clogging or stent migration. So this is 16% overall. But they also had, they did procedure for stent removal in embedded biliary metal stent. So if you read this paper, you need to read, I recommend you, you look at the pictures, you look at the videos, and then those of you who are experiencing enteroscopy assisted ERCP, think for yourself, could I be able to do this with an enteroscopy assisted procedure, even if I can do it? A patient that needs 2 or 3 interventions for clearance of hepatolithiasis in the right side, which will be easier for me? Just create a conduit and go back with a gastroscope, or do enteroscopy assisted? This is the question that I leave to you. And then the Americans rapidly saw that something was coming from Europe, and they decided this could not be, they have to have their own series. And they put together, and this is a nicely written paper, very nicely written, with just slightly lower number of patients, 18 patients, but not all of them were hepaticojejunostomy. There were 2 native papilla patients, so this is more heterogeneous. Also, there were out of these in reality, these 16 patients, 8 patients had malignant biliary obstruction. It's only 50% of the patients with Roux-en-Y hepaticojejunostomy who had benign disease, one could argue that for malignant biliary obstruction, you can address these very easily by EUS-BD proper, such as hepaticojejunostomy or antegrade stenting. So nonetheless, the results of the American series, multi-center, this is 7 hospitals over a period of 4 years, and they're only giving us 7 patients with hepaticojejunostomy and benign disease. So 1 patient every 4 years. So overall, the technical success was very high. And again, you see the same thing. There are patients with iterative EUS, and the Americans, they only did single session ERCP in 4 of the patients, which is, so this is another explanation. Why would you need this instead of EUS-BD or instead of enteroscopy assisted? This is a patient who had so many surgeries that we could not reach enteroscopy assistance. She had 2 transplant, cholecystectomy, 2 hepaticojejunostomy repairs, and she was referred to us from another region in Spain wearing a permanent external biliary drainage. And we did first EUS hepaticogastrostomy for internalization, and the leakage or the output stopped. But again, she was having cholangioscopy because she had a huge stone here and a kind of SAM syndrome. This is the surgical hepaticojejunostomy. So eventually, we had to go and create another anastomosis here with magnets. So we need antegrade and retrograde access combined. So we again did enteroscopy assisted, we did the bypass with the Axios, and once we had an easy access to this sump, we can put magnets above and below and create an outlet for them. And then this is non-hepaticojejunostomy. In other words, patients with a native papilla. We have very limited experience. I remind you that in the 18 patients multi-center US study, there were 2 patients like that. This is a bilio-pancreatic diversion. We have to create hepaticogastrostomy, and then through that hepaticogastrostomy, we put a nasobiliary drain to do real-time installation so that we can image from the afferent, the afferent limb, and then we have a 15mm lambs, and then after balloon dilation, in this case tract maturation, we can go. But eventually we were not coming so close from the papilla because it's very difficult to access the duodenum. So we had some distance to go. We had to use a colonoscope, and in the looping we were creating, we had stem dislodgement. Also, we didn't have the advantage of a side viewer endoscope, and because we have the nasobiliary drain coming out, we could do needle knife sphincterotomy, balloon dilation, because the indication was relapsing pancreatitis. And look at what happened when we were withdrawing the colonoscope. We have stem dislodgement, which is common when you are doing small bowel to small bowel. And the way we try to address stem dislodgement is by placing one lump into the other, but sometimes the 2 lumps comes apart, and is not very easy to breach stem dislodgement. What we do is use a double channel gastroscope so that we are pulling from both ends of the lumps into the second lumps, and that way we can breach. So my summary from this case and from our limited experience is that when you're not doing this in a patient with Roux-en-Y hepaticojejunostomy, the risk of stem dislodgement are higher. Before I conclude, what is the difference between EDGE and ED, I will say that for EDGE target location, the antrum is very easy. For ED, you require landmarking, sometimes via the PTC catheter, sometimes with a nasobiliary drain placed by enteroscopy, and sometimes by EUS-BD, injecting fluid and putting a drain. For EDGE, you are doing the procedure in a native papilla with a duodenoscope. You need a 20mm lambs, and it's very easy to do the freehand technique. For ED, 15mm is enough because you're going through with a gastroscope, and I will recommend a guide wire, even if you have a hot cautery-enabled stent, because the distensibility of the small bowel is less. The difficulty of EDGE is minimal. It can be learned very quickly. I don't think the learning curve is beyond 1 or 2 supervised cases. For ED, I would say is higher. They are more viable. Fistula closure is a concern, something that you need to address with EDGE. For ED, I will say that it is not the case. Is rather the opposite. You need to leave it patent to favor iterative access. I would say that for EDGE, there are some alternatives, like because the indications are very easy, stone removal, you can do this antegradely by EUS or by percutaneous. Patients with a gallbladder in situ is intraoperative, lap-assisted ERCP is an alternative. For ED, the properly selected patients, I would say that these patients have failed all previous alternatives, percutaneous, surgical, or even endoscopic by enteroscopy assisted. Again, this is 200 cases published. This is another important difference, whereas ED is less than 50 cases published. So this is evolving and this is less established, whereas EDGE is rapidly replacing other alternatives. So in conclusion, EUS-guided biliary drainage can be achieved by enterostomy in afferent loop syndrome. It will be a kind of indirect EUS-BD, such as using the gallbladder as a target for decompression in patients with failed ERCP and EUS-BD. There are 2 types of enterostomy for access as opposed to decompression in afferent loop syndrome. One is EDGE for Roux-en-Y gastric bypass, which has shown in meta-analysis superiority in efficacy compared to enteroscopy-assisted ERCP, and it's easier than lap-assisted ERCP with similar complications, and has the advantage that lap-assisted ERCP does not have of allowing iterative access. With the 20mm access, it can be done nowadays in single session. ED is an evolving new EUS-guided enterostomy approach that our literature and our experience favor for patients with Roux-en-Y hepatico-jejunostomy. I would say that in patients with native papilla, ED is not, there aren't many cases where it can be superior to enteroscopy or EUS-BD approaches, or even percutaneous as a risk for dislodgement. However, in Roux-en-Y hepatico-jejunostomy or Whipple patients with hepatico-jejunostomy, it can favor and simplify iterative access in benign disease. And I thank you very much for your attention, and I'm ready to take your questions if there are any.
Thank you.
Yes, thank you for very exciting presentations.
Thank you.
So I have one question. What kind of complications we have to pay attention? Peritonitis or bleeding?
Okay, peritonitis is a risk. The most common complication, so-called complication, is stent dislodgement. Then when you're trying to do the go to pass the duodenoscope through the lambs, And there is friction, especially with the edge in Roux-en-Y bypass, because the duodenoscope is rectangular, and in the past there were only 15mm lamps, or because of the angulation. There is an elbow, there is some looping. So that's the reason why some authors favor the two-stage approach. I create the gastrostomy or the enterostomy. I wait a couple of weeks, 2-3 weeks, if the patient is elective. And then if there is dislodgement, I have a mature fistula, so it's not a problem. In that case, stent dislodgement will not be a complication or an adverse event as such. So Anthony Tio has created a term that we discussed, which is called unplanned procedural event. So it's something that you don't like when you're removing a polyp and you get bleeding, but if you control the bleeding and the bleeding has no clinical consequences, the patient does not need a repeat procedure or a transfusion, I'm not sure if you can call that a complication. So to answer your question, there is a significant rate of stent dislodgement, which if it happens in a delayed, in a two-stage approach, is not a complication, and that I think it has a learning curve effect. It can be minimized by using 20mm axis for edge, but not entirely abolished. And most operators, most centers are developing strategies like the one that I show you to manage stent dislodgement, either by repositioning the dislodged stent or by creating another, or if you do in the second procedure, in the ERCP procedure, by suturing after the ERCP. So the true rate of peritonitis and bleeding not caused by the sphincterotomy, so you have the complications from the ERCP that we must assume is around 10% if you count everything like pancreatitis, sphincterotomy, perforation, and bleeding. And then the complications caused by the edge part of the procedure is between 5 and 10%, depending on your level of experience, the complexity of your case, and your approach. But I would say that serious bleeding caused by the edge, by the anastomosis, is under 2%, is less than or equal to the risk of sphincterotomy, and true perforation with peritonitis is hardly ever reported. I'm not aware of any cases that have needed like surgery, just some kind of endoscopic management of the complication.
Thank you very much. So Anthony, do you have any comment, or please
just
move to the next speaker?
EUS-guided enterostomy versus edge. So when you perform an enterostomy for like Roux-en-Y, the other side of the bowel is often collapsed, right? So is it more difficult for you to distend that bit of bowel?
Yeah, that I tried to highlight in the summary slide, whereas edge is a very easy, reproducible procedure. When you learn how to find the collapse antrum as the $100 sign, and we puncture and we inject and we distend until we make a nice target for the antrum. As you rightly point out, the afferent limb is often collapsed. So some of these patients already come with an internal percutaneous drain in place. So you need to distend your target. One way to do that is through the percutaneous drain. Even in the American series published in GIE this year by Moin Keshab, a senior author, and his team, they did very often the so-called finding the afferent limb by following the confluence of the right and left hepatic, and then the small bowel that you see next to it, even if it's filled with air and collapsed, you put a 19-gauge needle and you inject a lot of fluid. So in 15 out of 18 cases, before going for freehand or over the wire hot axios placement, they distended the small bowel by needle puncture. If we prefer to put a nasobiliary drain because we can use a pump that gives us immediate distension. Even if we lose the fluid or the contrast, we can re-inject all the time. So the other alternative in the case I illustrated with native papilla anatomy is you create a hepaticogastrostomy, because sometimes these patients are so complex that you have what we call a stage approach. You try a Whipple patient with hepaticogastrostomy, with a hepaticojejunostomy stricture, but then you realize there are some stones on the right side that you cannot access very easily with through the hepaticogastrostomy. I don't know, maybe Dr. Ogura or Dr. Itoi, that are very skillful in through the stent, can go to the right hepatic by putting antegradely a scope and then retroflexing and going to the right side. But for us, it's just easier. We distend the afferent lumen, we place an axios, we go with a gastroscope and go to the right side. So these are basically your three options for, or your four options, sorry, for highlighting the afferent limb. One is by direct puncture, by following the confluence of the right and left hepatic and distending with a 19-gauge needle. The other is by using a PTBD drain, either previously placed or a de novo place, and then by using EUS-BD or enteroscopy. But you certainly need to highlight your access before puncturing with cautery-enabled lamps.
All right. Thank you very much for your exciting lecture.
Thank you.
We have to move on to the last but not least lecture. Ogura Sensei has been waiting for a long time since this morning. So thank you for your patience. So Ogura Sensei will be presenting the next final lecture on EUS-biliary drainage as a means of biliary intervention. So Ogura Sensei.
Okay, thank you for your kindly introduction. Firstly, it is my great pleasure to present my lecture in AGE. So I'd like to talk about EUS-guided biliary drainage as a means for biliary interventions. Introduction. EUS-BD has been developed as an alternative method for treating biliary obstruction. EUS-BD itself is usually indicated for patients complicated with advanced malignant biliary obstruction. Recently, EUS-BD attempted not only for biliary obstructions, but also benign biliary disease. Transluminal treatment can thus be attempted across a fistula created by EUS-BD. So the aim is to present our technical tips for EUS-BD as means for biliary interventions. So you know, main indications of transluminal treatment are bile duct stone removal, structural resolution, or gallbladder stone removal. To perform these procedures, successful EUS-BD is firstly needed. So as you can see these images, fistula is very mature after the EUS-BD, so we can perform various procedures across this fistula. So regarding EUS-GBD, many reports using lumen opposing metal stent has been already published. So today I'd like to talk about technical tips for transluminal treatment through EUS-HGS route. So here is today's agenda. So first, I'd like to present technical tips for EUS-HGS briefly. So according to this financial study, manipulation of the guide wire is a very limiting step according to this study. So guide wire manipulation is one of the important factors to achieve technical success of EUS-BD. For successful guide wire insertion, the angle of echo endoscope might be important. As you can see in the left images, If the intrahepatic bile duct is punctured in this situation, the guide wire insertion into the hepatic hilera would be challenging. On the other hand, as you show here, right images, if the intrahepatic bile duct is punctured in this situation, a guide wire insertion into the hepatic hilera may be easy compared with left images. So indeed, our previously showed the echo endoscope angle is independent factor associated with successful guide wire insertion, like this. So regarding adverse events of EUS-HGS, several studies have evaluated the risk factors. According to those studies, a needle knife or electro cartridge later is a risk factor for adverse events, especially bleeding. So we also evaluate risk factors of adverse events, especially bile leakage. So according to our studies, long procedure time is associated with bile leakage. So the use of cartridge later or long procedure time might be associated with adverse events. Therefore, stent deployment without fistula dilation is ideal. Recently, we reported on one-step EUS-HGS procedures. So you can see this stent delivery system is only 5.9 French delivery system. So after the intrahepatic bile puncturing, we can insert this stent delivery system without any dilation, fistula dilation. So I'd like to show the video. So the intrahepatic bile duct is punctured using 90 gauge needle, and the contrast medium is injected. And then the guide wire is gently inserted into the common bile duct, or like this. So next, fine gauge stent delivery system inserted into the intrahepatic bile duct without fistula dilation, and the stent deployment is successfully performed. So adverse events such as abdominal pain or minor fever up was not observed. To date, 14 patients have undergone these procedures. So you can see here the procedure time was only 7 minutes. So however, focal cholangitis was complicated because this metal stent is fully covered metal stent. So this patient underwent stent exchange to the type IT produced by Professor Itoi. So however, among 13 patients, abdominal pain or bile peritonitis was not seen in any patients. So, you know, as we all know, stent migration into the abdominal cavity is a critical adverse event of EUS-HGS. To prevent stent migration, intrascope channel release technique is very useful. So, the intrahepatic bile duct is punctured using 90 gauge needle, and the guide wire deployment is performed. And then we usually dilate it using balloon catheters. Intrahepatic bile duct and stomach wall were dilated using 4 mm balloon catheters. And then stent delivery system is inserted into the intrahepatic bile duct like this. Next, stent release was carefully performed from the intrahepatic bile duct to the echo endoscope up to 4 centimeters. So by doing so, stent release was certainly performed across the stomach wall. So we believe early stent migration can be prevented using this technique. So finally, stent release was completely performed under endoscopic visualization. So indeed, stent deployment using this technique, adhesion between hepatic parenchyma stomach wall can be obtained. So next, I'd like to talk about transluminal stone removal. Here is a case of an intrahepatic bile duct stone. So this patient underwent distal gastrectomy and right hepatectomy previously. So, however, frequent cholangitis was observed due to the intrahepatic bile duct stone here. So we firstly performed EUS-AGS using covered metal stent. So we previously reported on technical tips for perioral transluminal cholangioscopy using SPY-DS. So after the fistula formation, various treatment under SPY-DS can be performed through EUS-AGS like this. So this patient underwent EHL under SPY-DS guidance like this, and we successfully stone removal transluminally. So this slide shows patient characteristics for those who underwent transluminal stone removal at our hospital. To date, 14 patients underwent this technique. All patients received this procedure due to surgical alternated anatomy. The mean bile duct stone size was 24. So I'd like to show the common bile duct stone removal. So firstly, we performed EUS-AGS. The intrahepatic bile duct is punctured and the guide wire is gently inserted like this. And next, ERCP catheters is inserted into the common bile duct. So you can see here the bile duct stone, you can see here. So we performed EUS-AGS using covered metal stent temporarily. So in my hospital, after 1 week, we tried to stent removal. First, ERCP catheters is inserted into the biliary tract through the mesh. Mesh was broken using ERCP catheters like this. And then the guide wire is inserted into the common bile duct. Next, covered metal stent was removed using forceps biopsy device. So by doing so, if the fistula is not still created, because the guide wire is also still placed, so we can easily re-intervention. So because this fistula is created, we insert the SPY-DS like this. And then we can detect the common bile duct stone here. So compared with antegrade stone removal, transluminal stone removal to prevent pancreatitis. So I prefer this technique compared with antegrade stent removal, also very high cost. So we catch the common bile duct stone using a SPY basket. And the gently SPY-DS itself removes that transluminally. So here is a bile duct stone, bile duct wall, and you can see the HGS fistula. This is fluoroscopic imaging. And we successfully transluminal stone removal. So transluminal stone removal has several advantages, such as reduced risk of pancreatitis or bleeding due to EPBD or large balloon dilation. But this technique has also several disadvantages, such as prolonged hospital stay or high cost. In addition, removing a stone in the right hepatic bile duct is challenging. However, recently, novel basket devices has been available in Japan. So I'd like to show a case of right hepatic bile duct stone. This patient underwent pancreatoduodenostomy previously. However, frequent cholangitis was observed due to the right intrahepatic bile duct stone. So you can see the right hepatic bile duct stone. In addition, hepatic jejunum structure is also complicated. So we performed the EUS-AGS firstly. After the fistula creation, firstly, jejunum stricture was dilated using 8 ml balloon catheters, and also EHL was transluminally performed. And then novel basket devices inserted into the right hepatic bile duct with successfully stone removal. So among 14 patients, EUS-HGS itself successfully performed in 18 patients. 2 patients failure due to insufficient bile duct dilatation. And also successful EHL was obtained in 36 patients. Finally, complete stone clearance was obtained in 84%. In addition, pancreatitis or bleeding was not seen in any patients. So finally, I'd like to talk about transluminal treatment for benign biliary stricture. So main indication of this technique is video anastomotic stricture, such as hepatico-jejunum stricture. So either enteroscopic or EUS-guided access can be selected for patients with surgical alternative anatomy. According to this international collaborative study, technical success was achieved in 98% in the EUS-BD group compared with 65% in enteroscopic ERCP group. Also, procedure time was significantly shorter in the EUS-BD group compared with enteroscopic approach. So given this background, we recently reported on novel treatment protocol for hepatico-jejunum stricture using fully covered metal stents. So here is a treatment protocol. EUS-HGS is firstly performed using a fully covered metal stent. And 1 week later, the SPY-DS is inserted into the biliary tract to evaluate the HGS site. If the cholangioscopic and histological findings confirmed to benign biliary stricture, this site was dilated using balloon catheters. So I'd like to show the video. So compared with malignant biliary obstruction, the intrahepatic bile duct is not so dilated in hepatico-jejunum stricture patients. So the intrahepatic bile duct should be punctured gently, and also guide wire manipulation is also gently performed. So we using the liver impaction technique, we can advance into the right hepatic bile duct. The guide wire was successfully inserted. And after fistula dilation, we temporarily performed EUS-HGS using fully covered metal stent. So we successfully performed EUS-HGS without any adverse events. So after 1 week, we insert the SPY-DS. You can see here the very hepatico-jejunum structure, hepatico-jejunum site is very structures. So guide wire passage was successfully performed under SPY-DS guidance, like this. So we successfully inserted into the intestine across the structure site, like this. And then SPY-DS is removed. And also this site was dilated using balloon catheters. And then to keep the fistula, we deploy the plastic stent, type IT stent. Sorry. So, however, after 3 months, stent exchange, we performed 3 months. If HGS is still present, we performed antegrade stent deployment or antegrade electrocartilage dilation. So for antegrade electrocartilage dilation, we use this novel electrocartilage dilator. This top is only 3 French, so burning effect might be fewer compared with conventional electrocartilage dilator. So also for antegrade stent, we use M intraductal metal stent. So I'd like to show the video. So this is a structure site. We insert the novel fine gauge electrocartilage dilator. So we perform the antegrade dilation like this. Here. So to evaluate the burning effect, we insert the SPY DS. So you can see the no bleeding or perforation was not observed. So next, I'd like to show the antegrade stent deployment. After the guide wire passage, we insert the M intraductal stent inside the stent. So we carefully release the stent released into the from the intestine to the intrahepatic bile duct like this. So to keep the fissure, we also deploy the plastic stent. To remove this metal stent, we made the modified ERCP catheters. First, tip of ERCP catheter is cutting. So by doing so, we can insert the SPY byte device like this. So I'd like to show the video. After the double guide wire deployment, we insert the modified ERCP catheters. And then SPY byte is inserted into the ERCP catheters. So we catch the antegrade stent using SPY byte at the proximal site. So by doing so, we can remove this stent transluminally. Like this. So we attempted this technique is for 8 patients. As a result, technical success and clinical success were obtained in all patients. In addition, adverse events was not seen in any patients, but very follow-up time is short, so further study is needed. So in summarize, advantage of this technique is a shortened procedure time and easy accessibility in re-intervention. On the other hand, longer-term outcome remain unclear, so further study is needed. Okay, in my conclusions, indications for EUS-BD has notably grown. Once a fistula is created between the intestine and the biliary tree, a variety of interventions can be attempted. This technique has a high potential, I believe. However, further comparison studies are needed with long-term outcome. Okay, thank you for your kind attention.
Thank you. So
thank you, Ogura Sensei. Very beautiful presentation.
Thank you very much.
So very nice technique of removing the intraductal stent through the HGS. So what happens if you encounter a patient, the XJ is completely stenosed, no opening? If there's, when you insert the SPY, if you go to the XJ, there is no opening, then what are the options? Ogura Sensei? Can you hear me, Ogura Sensei?
Sorry.
Yes.
I'm sorry. Okay.
What if you insert a SPY DS, the XJ is completely stenosed, no opening. So what can?
Okay. So this is very difficult situation. So we introduce enteroscopic and to the hepatico-jejunal structure site using enteroscopy. And also we insert the SPY DS. And the SPY DS can be observed from the intestine route. So because bright. So we insert the guide wire, the stiff site, insert the guide wire, and catch the this guide wire using SPY snare, and such as a rendezvous technique. Okay.
So,
Anthony,
yes.
yeah, probably it's time to close the seminar.
Okay. Yes. Yes. So
Sorry.
thank you very much, everyone. It was a long day, but I think everyone enjoyed the seminar very, very much. Thank you all our faculties for your hard work. Sorry to make you sit in front of the computer for a whole day. I think Flora will post the live footage of the whole seminar online later. And Vinay will have another web seminar in 1 month's time on the topic of EUS stents. So once again, thank you very much. Thank you all the participants, and thank you all the faculties.
Yeah, thank you very much, Anthony, organizing such a wonderful webinar. It's I'm so impressed, and I feel so my heart is so exciting. It's very interesting, but I expect face-to-face meeting in the near future. I strongly expect. Thank you very much.
Okay, thank you. Bye-bye.
Thank you, Theo. Thank you, Manuel. Thank you, Nosoli. Thank you, Flora.
Thank you.
Thank you.
Here in Colombia is 4 a.m. in the morning.
Wow.
We're with you long time.
You are the only one awake. Huh?
Well, have a
Bye-bye.
good night.
See you
Bye.
1 month. Bye-bye.
Yes, yeah, thank you, everybody. Goodbye. See you.